by 3 investigators later. Study selection was observational. They included observational studies of adult patients presenting to trauma centers level 1 and 2 in high-income countries like US and UK, mild and moderate TBI cases, and compared the rate of early post-traumatic seizures among patients with seizure prophylaxis with those without seizure prophylaxis. Most of the studies used levetiracetam, phenytoin, or valproic acid. Only 3 studies used only levetiracetam as the drug of choice. Inclusion criteria was the studies that compared seizure prophylaxis in early post-traumatic seizures to a control group after mild or moderate TBI. Defined seizure prophylaxis are any anti-seizure medication, but most of the studies used phenytoin, levetiracetam, or valproic acid. Exclusion criteria was age less than 18 years, no comparator or studies which has no comparator or control group, stratifying TB severity alternative using another scale, or failure to report the rates of PTS within 7 days. Like some studies, they didn't include the first 24 hours of injury, 24 hours from the injury as in this period, and patients with the pre-existing seizure disorders, and from low and middle income countries. They prepared a Prisma flow diagram. Total of 896 records were identified through database searching. All 896 titles were screened by 2 researchers, and 704 records excluded during title screening itself, and 192 abstracts were screened, and 128 were excluded, and 64 full articles were assessed for eligibility. 56 were excluded because 18 were book chapters, narrative reviews, or letters to the editors. 13 were GCS 13 were GCS data were not available. 11 included severe TBI cases. 9 cases had no relevant outcome data. 3 were non-humane studies. 2 studies from World Bank designated low-income and middle-income countries, and from that 8 studies included for primary outcome measure. This full text analysis start from here. This 64 studies were screened by 3 researchers. From these 8 studies, 3 excluded that it did not report mild TBI results separately, and 5 studies included for secondary outcome measure in mild TBI.
Okay, I want you to pause a little bit. A few notes that I wanted to tell you. Like whenever you do a systematic review or meta-analysis, this Prisma flow diagram is a must, basically, because this basically tells the readers how you searched for the articles and what was the process you took to screen out the irrelevant articles. So in this, like even before this, they should be mentioning what all keywords they used for searching the Google Scholar, PubMed, and Web of Science, etc., etc. So after that, how many records they found? After that, title screening, abstract screening, and after that, full text screening, followed by the reasons for excluding articles. And after that, you usually end up with a very tiny number of articles. Like here, they ended up with 8. Okay. So I want to emphasize on the fact that doing a meta-analysis, this is the hardest part of the job. Like this basically is the time-consuming part. Once you have done this, the analysis is fairly straightforward. Like literally, it can be done with 3 or 4 lines of code or 3 or 4 button pushes. Once you have gotten the relevant data out in the table that she will show in the next slide. Okay. Now, Athira, you can describe the next slide.
These are the 8 studies which they have included in this article. Out of 8 studies, only 2 were prospective studies. All others were retrospective studies. Only 1 study included just mild TBI. All other studies included mild to moderate TBIs. Only 3 studies included levetiracetam as only anti-epileptic drug. All other studies included any other drugs. They studied a total of 1,518 patients were studied for received seizure prophylaxis during the study period, and 4,000 patients didn't receive any seizure prophylaxis during the study period.
So one more point here. So basically, whenever you are comparing these type of groups, like in which you have incidence in one group versus incidence in another group, like in incidence in control group versus incidence in the intervention group, in those, the certain important effects can be found out. So effects basically meaning the statistical parameters that we are interested in that will convey what we need to convey to the readers. Okay. So the simplest statistical parameter that can be gotten from this type of study is incidence 1 minus incidence 2. That is giving the seizure prophylaxis, what is the incidence of PTS, and not giving the seizure prophylaxis, what's the incidence of PTS. You subtract the two, and that is called absolute risk reduction, or ARR. Okay. It can also be known as risk difference, or RD. Okay. There can be, so in this study, they have used the ARR as the statistical parameter that they want to present. It is one of the simplest ones, and it's easy for a person to understand. The other parameters that can be derived from the same data is a relative risk, or RR, and odds ratio, or OR. So both of them are sort of similar. I think most of us know how to what you say interpret the odds ratio and the relative risk. Here we'll be talking about the ARR, or the absolute risk reduction, or risk difference, RD. Okay, so Athira, you can continue. Athira, I think you're disconnected, or your
Sir,
presentation. Your presentation we cannot see. Like you have to share your screen again, I think.
am I audible, sir?
You are audible, but your screen doesn't show your screen basically. You are not sharing the screen. Dr. Lenin, I think you need to mute your audio because, yeah. Athira, can you share your screen?
I am trying, sir.
Okay,
There is a power related issue, sir. It's raining here.
I understand. I understand.
Is my screen visible now, sir?
Yes, but the PowerPoint is not visible.
Now, sir?
No, PowerPoint is not visible. Shall I
Now?
share? No. Shall I share the PPT and you speak? Is that okay? Like I have your PPT ready here.
Now, sir? Is it visible, sir?
No. It's not. Ah, now
Okay,
it's
sir.
visible. Now it's visible. Yes.
Okay, sir.
Okay, continue.
Study quality assessment was done using Newcastle Ottawa scale. It is a Cochrane recognized quality checklist. It contains eight items categorized into 3 domains. There are 4 items in selection and 2 items in comparability and 3 items in the outcome. Evidence grading was done with the new scale NOS, and it showed a good quality. All studies included in this article was good quality studies, according to the article.
No, continue. I think this is
Data
fairly
extraction was.
Yeah,
Sir?
continue.
Okay, data extraction was and synthesis was done using the Prisma reporting guidelines were used. 2 authors were independently reviewed all titles and abstracts, and 3 authors reviewed the final studies for inclusion. Meta-analysis was performed using random effects model with the absolute risk reduction, and protocol. This protocol was registered with the Prospero. The main outcome measures was absolute risk reduction of early post-traumatic seizures, defined as seizures within 7 days of initial injury in patients with mild or moderate TBI, receiving seizure prophylaxis in first week after injury. A secondary analysis was performed in patients with only mild TBI.
Now I want you to pause, Adira.
Okay, sir.
So the way this analysis for the effect measure of any meta-analysis is done can be done using three ways. Okay, one is called fixed effect analysis, one is called random effect analysis, and one is called mixed effect analysis. Okay, now you will
Okay,
see
sir.
these three terms. I want you to understand what these three terms mean. Fixed effect analysis means that the studies that you are including are the only studies that are ever going to be performed on the subject, and the effect that you are getting from the studies is uniform, is homogeneous across the studies. Meaning that all the studies have been done in a very uniform, homogeneous manner. There is not much heterogeneity in the study design, outcome, etc., between the studies. And because of that, you are doing the fixed effect design. So the outcome from that, whatever summary statistic you get from that, also means that summary statistic is Senthil, can you please mute your audio? Senthil, can you mute your audio? Okay, I'll continue. So the fixed effect model means that whatever results you are getting from that will be applicable only to these studies and cannot be generalized to any other study which will be done in the future. Okay, so because of whatever I described, you can understand that most of the assumptions which go into fixed effect modeling are not going to be realized in real life. So nobody uses fixed effect modeling for this type of analysis. Next comes your random effect analysis. In random effect analysis, all of the studies are determined to be heterogeneous, like they are assumed to be heterogeneous. So because of that, that heterogeneity is taken into account as well as it is calculated as a separate statistic to give an idea to the viewers that how much heterogeneity is there between the studies, as well as the effect size will mostly be lower than the random effect, the fixed effect studies. Okay. So most of the studies you'll see will be doing the analysis in a random effects fashion. The last one is a mixed effect analysis. In the mixed effect analysis, you want to account for certain things. Like suppose in this study, they had a column that some studies used any anti-epileptic, some studies used levetiracetam. So if you want to include this discrepancy as part of your model to adjust the statistic that you are calculating, then you use a mixed effect analysis in which the random effect is also taken care of and some extra covariates that you want to account for are also taken care of. So here they did not go for that approach, at least what is written in the statistical analysis portion. What is written is they went for a random effect analysis. Okay. Now coming to the okay, can you describe this table and diagram, Athira? Or shall I do it?
Sure.
Okay, I'll try to, I will explain it. So whenever you come out with, whenever you get the results of a random effect analysis, what you'll be getting is the effect for each of the studies and a summary effect at the bottom, which is like a overall averaged effect from all of the studies. In this, the risk difference, like you are seeing for Inglet et al., it is minus 0.01. That, sorry, please go up, Athira. Minus 0.01. This basically says that when you give your PTS, sorry, when you give your early, what is the anti-epileptic drugs, then your early PTS, there is a 1% reduction in the incidence of early PTS. So 0.01 means 1%, minus means reduction. So giving the drug leads to a 1% reduction. Similarly, you can see for all of them, there is 1%, 1%, 1%, 2%. But in D. John et al., it is showing as 4% increase. So that is a very discrepant finding from all the other studies. So this is likely to screw up the results a little bit. Dr. Gopinath, can you mute your audio? Yes. So this Dijon is a little discrepant from the other studies. And because of that, you can see that it is in the funnel plot, it is disjointed. Like you can see that it's on the right side of the zero line. Okay. So this plot that you are seeing is called a funnel plot. Okay. So this, sorry, forest plot. This is called a forest plot. In this forest plot, the middle boxes that you are seeing, the squares, they are the risk difference, and the side lines that you are seeing, that is the confidence interval of the risk difference for that study. Okay. And at the bottom, you are seeing a diamond. That diamond is basically the summary statistic, that is the averaged risk difference across all of the studies with its confidence interval. So this one also shows that your summary statistic is 1% reduction with your confidence interval from 1% reduction to no reduction, that is 0. Okay, so this is how you interpret a forest plot as well as the table for your table that you get after a meta-analysis. Now let's go to the next one. This type of plot, yes. Adria, you want to speak? Please speak.
No, sir.
Okay. So this type of plot is called a funnel plot, in which you are plotting the risk difference that you are getting with the standard error of the risk difference for each of the studies. So this basically shows that how good is your risk difference. If your risk difference is small and your standard errors are large, then you will have a very wide funnel. Otherwise, you will have a very narrow funnel. You want a narrow funnel for more precision. Basically, you can trust a narrow funnel, you cannot trust a very wide funnel. Okay. Now, how wide of a funnel you can trust and all that is very qualitative. Okay. In that also, you can see that the Dijon study is coming far right at the 0.04 mark of risk difference. That is outside the funnel. So this type of diagrammatic representation is also useful for finding studies which are discrepant from the usual studies. So later on, you can choose to, by giving some justification for removing those studies, but these people chose to keep that study in the mix. Okay, but this study definitely, the results of this will definitely affect the final summary statistic that we are getting. Okay, so this is like a visual representation of the studies, how they cluster together, how much variability they have, and in their effect, and also finding outlier studies. Okay, so now we'll move on to the next slide.
Out of 64 full articles were reviewed after screening. 8 studies including 5,637 patients were included for the mild and moderate TB analysis, and 5 studies including 3,800 patients were included for mild TB analysis. The absolute risk reduction ratio of seizure prophylaxis for early PTS in mild to moderate TB was 0.6% with a confidence interval of 0.1 to 1.2% and p-value of 0.02. The number needed to treat the seizure was 167 patients for one seizure episode.
I'll stop you here, Ajra. So here you are seeing there are two statistics given. One is the average absolute risk reduction, that is 0.6%, and the number needed to treat. This number needed to treat is nothing but the inverse of the absolute risk reduction. So if you divide like, it is like 6.6%. So basically, yeah, if you divide 100 by 6, sorry, 1000 by 6, because it is 0.6. So if you divide 1000 by 6, you'll get the number of 167. Okay, so that there's nothing much in the number needed to treat. Okay, go on, Athira.
Okay. The results of this meta-analysis suggest modest effectiveness of seizure prophylaxis in mild to moderate and mild TBA. Despite of lower ARR and in mild moderate TBA, early seizure may have a clinically significant effect in populations with mild and moderate TBA because early seizures prolong hospitalization and causing non-discharge and prolonged use of anti-seizure medications and unnecessary advanced diagnostic testing and driving and work restrictions later, and reducing the seizure burden improves the functional outcome and quality of life in critically ill patients. So even though the ARR is lower and incidence of early seizures are also lower, whatever is occurring is clinically significant. This is the subgroup analysis of mild TB.
You can try and explain this, Adira, based on whatever we discussed in the last slide.
Sir, the reduction, England et al. In the study is published in 2016 by England et al. Showed a 1% reduction, and next study showed 2% reduction. The next one showed a 0.1% reduction, and in total, they summarized like there was a 0.01 minus 0.01, like 1% reduction in total using for patients using early seizure drugs for early seizure prophylaxis.
Definitely, you can go to the next slide.
This is the funnel plot of mild TBI.
Interpretation is
This
same
is
as the previous one. What?
okay, sir. Yes, sir. Subgroup analysis for mild TB was also showed similar, like 0.6% of risk reduction. How does our analysis reflect?
Okay, I'll stop you here, Adira. Can you just go
Okay,
to the previous previous 3 slides? Like go to the mild TBI one, in which the forest plot is shown. Yes. So in this and in the previous one also, all of you would have seen that in the summary, they have written minus 0.01 with a confidence interval of minus 0.01 to 0. However, in the text, they have said it is 0.6%. Can you go to the next slide? And the next slide, Adira? Yes. So here in the text, they are writing the absolute risk reduction is 0.6% with whatever confidence interval and some p-value. Okay. Now, there is a major discrepancy here. Are you all able to appreciate? Like for both of the mild to moderate as well as mild TBI, in the text, they have written it as 0.6% of absolute risk reduction. Well, nothing of that sort is being shown in the tables and the graphs that they have presented, with summaries being close to minus 0.01. That is only a 1% reduction with a very little wide confidence interval. Okay. Now, this thing actually piqued my interest a little bit because I just could not find where they have calculated that 0.6% from. So last night, what I did was, can you go to the next slide, next slide, Athira? So like I said, the analysis of this type of study is quite easy to do. Like all you need is the column of seizure prophylaxis, PTS, no PTS frequencies, and no seizure prophylaxis, PTS, no PTS frequencies. So it basically becomes a contingency table, A, B, C, D types, but like a cross tab basically. Okay. So from that, it is fairly easy to do the analysis in a random effects fashion, fixed effects fashion, if you know how to do it. So the way they described in this study is using R software with a package called Metaphor. So I got that same package and I did that same analysis. Okay. And I'm getting the same results that they are showing in the graph and the table. Okay. Can you go to the next slide? Next slide. Yes, next. Next also. Just open it. Yeah. So basically, this is the forest plot that I got for your random effect model and the fixed effect model. Like I did it in both ways, random effect modeling as well as fixed effect modeling. Okay. And their graph, this is for the mild to moderate TBA, and their graph and table match exactly the fixed effect modeling that we have done. Okay, so basically the same numbers are being used, the same, this one is being shown, the absolute risk reduction, the risk difference for all of the studies. And the summary statistic is also the same, but this is for the fixed model. In the random effects model, you can see that the confidence intervals are from minus 0.02 to 0.01. It is crossing the boundary line of 0, meaning that it is not statistically significant. However, in the fixed effect model, it is somewhat statistically significant because both of them are on less than 0. Okay. So because of this, like I feel that their study, they have messed it up somehow, in which they are reporting something, they are showing a wildly different graph and forest plot, the table and forest plot, and also the statistical procedure that they have used, that they have described, is also wrongly written out, because the results that they're showing is showing from the fixed effect modeling that we have done. Okay. So I feel that this calls for writing a letter to the editor of this journal that there is a major discrepancy in the reporting of the results that these people have done. And if anyone wants to take it up, I would prefer if Athira takes it up to write the letter to the editor. It will be a nice addition to your publication list also. Okay.
Okay, sir. Okay, sir.
Now go to the next slide. So yeah, so this is where I'm pointing out where the differences are. So basically they are showing the ARR, the overall average ARR to be 0.6% with whatever confidence interval and p-value. However, and they are quoting figure 2. While when you go to figure 2, the summary statistic that you're seeing at the bottom is minus 0.01, minus 0.0120. And the forest plot is also that. And this is the exact same thing that we got from our fixed effect model. Remember that. Okay. And the same thing I have shown, the output I have shown in the numeric output I have shown on the side. So in that the exact, like here it is minus 0.01, but if you expand the decimal points, it is minus 0.0052 for your random effects model and minus 0.0061 for the fixed effect model. Okay. And this fixed effect model is significant with a p-value of 0.039, 0.04, and the random effects model is not significant. So I think they are doing some gabla in their reporting. They are putting the fixed effect modeling, this one, graph and table. But in the, like I tried to exclude studies one by one to see if your, at any point of time, I get the 0.6% that they are speaking about. Then I thought that maybe they reported the wrong statistical measure. So basically, instead of ARR, they calculated maybe the OR or the RR. I went for those also. In those, it is coming somewhere close to the 0.6 number. Like the OR is coming somewhere close to 0.6, but the confidence intervals are widely different. So I don't think they have done that also. So I do not know where they have dreamt up this number of 0.6% from. But this is a major cause of concern because their entire discussion is based on this 0.6 number that they have gotten. So I feel this is an important discrepancy that needs to be pointed out, because they are trying to shove the idea of PTS in our faces. So the early PTS and early administration in our faces, while not being able to justify the same in their numbers. Okay, so this is something that needs to be taken up. Go to the next slide. This is the same analysis I have done for the mild TBI only. In that also the numbers are matching the graphs, but like there also they have reported 0.6% in the text. So I don't know where they got it. Continue.
So, what was their finding was in the systematic review and meta-analysis, including 8 studies, absolute risk reduction for seizure prophylaxis was 0.6% in mild and moderate TB. The overall rate of PDS was low, ranging from in mild to moderate TB was also low, ranging from 0 to 4%. Meaning, our study results suggest seizure prophylaxis associated with a small but significant reduced risk of early PTS for mild to moderate TB. A small risk reduction should be weighed against the risk of prescribing anti-seizure medications. The relevance is seizure prophylaxis is after mild and moderate TBA was associated with a small but statistically significant reduced risk of early PTS and small absolute risk reduction and low prevalence of early seizures should be weighed against the potential acute risk of anti-seizure medications as well as the risk of inappropriate continuation of medication beyond 7 days. As I said before.
Yeah, so all of this is basically being based on the numbers that they have quoted of 0.6, which are
0.6.
clearly not true. Yes. Go
Limitations of this study was there were many, were only 2 were prospective studies Out of 8, 6 were retrospective studies. There were no randomized control trials, and need of huge study population was required, like more than 10,000 people, and it was not feasible. To study mild TB, there was an issue with a poor follow-up and small effect size like 0.6%, and there is a small risk of early PTS in mild to moderate TB patients too.
So this is one thing that you will be finding in many studies, and even in some of the studies that we will be conducting in the future. Wherever you have a low event rate, meaning that the outcome of interest of has a low event rate, your sample size increases up exponentially. Okay. So because of that, it is very difficult to get scientifically feasible answers to these type of questions with limited resource scenarios. Okay, this type of things usually call for either a major funded study like they tried to do for the crash trial for the steroids, like they tried to do something by going up the sample size, or even the Navis Edge. They also tried to go up the sample size or tried to refine the question. They ended up with a large sample size, but they could not find anything in that because the outcome in that the outcome was poor in the crash study. In Navis Edge also, they could not find any outcome. Okay. So here the scenario is a little different, in which you require a large sample size to get even a few cases of early PTS. And also whenever you get these type of data, the analysis also has to be deferred a little bit to account for this low event rate. Otherwise, you will never find anything useful. Okay, so continue.
Critical appraisal of the systematic review. Is the study design valid for a systematic review? Did the systematic review address a clearly formulated research question? Yes, research question was clearly formulated. Did the researchers research for appropriate study design to answer the research question? Yes, it was done. Were the all relevant primary research studies likely to have been included in the systematic review? Searching was done using PubMed, but other sites like Embed and Medline were not used. Screening the primary research studies from search was done using 2 researchers independently, and selecting primary research studies to include the systematic review was done using, they were sticking to the eligibility criteria they have formed, and 2 researchers worked independently for screening, and the third one was used to resolve any disagreements, but it happened during the screening period. For summarizing the search and its outputs, they used Prisma flowchart. So the all relevant primary research studies likely to have been included in the systematic review. Answer was yes. Did the researchers assess the validity or methodological rigor of primary research studies included in the systematic review? They used Newcastle-Ottawa scale. It was a Cochrane accepted checklist. Did the researchers extract and present information from the individual primary research studies appropriately and transparently? No, they couldn't do it because most of some centers were not willing to share the data, personal data. Some were like not reachable because the email IDs were not working. So they couldn't obtain the complete data. Are the results of the systematic review are trustworthy? Negative parts are they did not undertake a sample size estimation. They did not provide minimal important difference. There was no reason for heterogeneity. Positive parts were the effective measure was defined. Confidence interval and p-values were given. And I-square was used. And random effect model meta-analysis was done.
Here I'll stop you, Athila. So this I-square is, just 1 minute. This I-square is a statistic which defines the amount of heterogeneity that is there between the studies. So it is usually represented as a percentage, and the higher the percentage, the worse is the heterogeneity. So less is the trustworthiness of the result. The same thing can also be tested by a specific statistical test called Cochrane's Q. So once you conduct that test, if you find it to be statistically significant, that is less than 0.05 p-value for that test, that means that there is significant heterogeneity and the results have to be observed with caution. Okay, so this I-square and the Cochrane's Q are important parameters that you need to report for any meta-analysis. And here they have done that, but I was not able to replicate the I-square or the Cochrane's Q that they got in the analysis that I did with the same data. So I do not know where they got those numbers from. Continue.
Okay.
Adira, no
Sir,
reason for heterogeneity. Why is it negative? Why is it a negative point?
Explain, Adira.
they haven't mentioned the reason for heterogeneity, ma'am.
Actually, the thing is that in their text, if you see, they have reported the I-square to be quite a low number and the Cochrane's Q to be not significant. So because of that, they did not find, they reported that they did not find any heterogeneity between the studies, significant heterogeneity between the studies. However, as you can see directly from that one study, in which the effect was 0.04, that itself introduces a massive amount of heterogeneity, especially if you do a mixed effect modeling. Sorry, the random effect modeling. So I think like in the slide that showed the numbers that I got from the analysis that I did, in that you will see the I-square is a little on the higher side, the number. So
Also, Ditiman, if one of the studies, the third one in the mild TBI,
yes,
had a very wide confidence interval,
yes.
will that also add to the heterogeneity?
No, ma'am, that is the final answer that you get after you account for the heterogeneity, meaning that it is not significant because of the excessive heterogeneity. Like the wide confidence interval tell you that there is excessive heterogeneity in the effect estimates that they got.
Thank you.
We'll continue after that.
Did the researchers report any limitations of the systematic review? And if so, do the limitations discussed cover all the issues you have identified using critical appraisal? Yes, but confounders were not discussed, and we have doubts about the precision of numbers they have obtained now. Like as sir mentioned, what they have plotted in the graphs were 0.01%, and it is mentioned in text as 0.6%. Would the benefits of acting upon results outweigh any potential disadvantages, harms, and/or additional demand for resources associated with the acting on the results? Yes.
So this last question that she addressed is mostly a clinical question that you cannot speak about from a statistical point of view, because in the statistics you are not accounting for the actual disruption that having a seizure, even if it is a low probability event, but if it happens, it screws up the patient's life, right? So because of
Yes.
that, it's a clinical thing that you need to decide by yourself, and that is why I think we administer the anti-seizure medication even for a longer period of time, despite having no evidence for effect on late post-traumatic seizures. Continue.
Can the results be applied to your local population in your context? Although we belong to low middle income country, we can apply this. Would the findings from the systematic review provide a greater value for the individuals or population for whom you are responsible? Actually, can't tell because we are already using this.
Mostly it doesn't provide any extra benefit to us, like the answers of this, and anyway we are not able to trust the answers of this systematic.
Positive parts were 2 authors and a review team was done, and they defined the eligibility criteria. Prisma flowchart was used, and included study were validated. Negative part was there were no RCTs. They were unable to obtain complete original data of included studies. Only one subgroup analysis was done. And it was done only in high income countries. Recent ongoing studies were not included, like up to 2023 only it was included. Searched using only English language. Since we are already practicing it, couldn't make it like not much practice changing.
If anybody has any questions, I'm happy to answer them. We have managed to finish this in half an hour. I'm very proud of that. No, actually 45 minutes. If anybody has any
Extremely
questions.
well done.
Yes, sir?
Extremely well done. Thank you very much.
Thank you.
Thank you, sir.
Adira,
Thank you,
your
ma'am.
efforts are commendable. And
Thank
I
you, ma'am.
hope you will abide by what he has suggested. Write up. It will be a nice one. Very nice one, actually.
Okay, ma'am. Thank you, ma'am.
Any more questions? Please come forward with it. If not, Dhirtiman, thank you very much for another wonderful session.
Sure.
Enlightening as ever. Hope we have 1 or 2 more sessions with you.
Definitely.
Thank you very much.
Very happy.
See you all.
Thank you,
Bye.
sir.
Good night. Thanks, Adira.
Thank you.
Bye. Good night.